My name is Carl Chemnitz. I'm Deputy Provost here at San Jose State University, and I'm very proud to welcome you to our second of the University Scholar Series this spring semester. This is our 15th year hosting this, where we have faculty members showcase their outstanding research, scholarship, and creative activities. And we, in this case, this afternoon, we have Nidhi Mahendra. She joins us and is an associate professor of communicative disorders and sciences in the Connie L. Lurie College of Education. She'll discuss some recent research in a presentation entitled Neurological Accidents, Brain, Behavior, and the Power of Rehabilitation in Alzheimer's Disease and Stroke. She's an expert in healthy aging, dementia, aphasia, cultural and linguistic diversity, and swallowing disorders. Her research explores contemporary post-stroke intervention models and communication patterns among persons with dementia. In these and related topic areas, she has published 50 peer-reviewed journal and newsletter articles, book chapters, and commentaries. Wow. She has been an invited speaker at 42 professional and private organizations and presented 70-plus conference papers. She has held invited lectureships at St. Louis University and Michigan State, and her research has previously funded by the Alzheimer's Association, the Hartford Foundation, the California Wellness Foundation, and the Masonic Homes of California. And she provided all the swag that's on the tables here, including these fabulous little brains. So I'm excited about that as well. But before we begin, let's take a moment to thank those who put together this program and provided the food and space and organization. That's the staff in the University Library, the Spartan Bookstore, Risk Advisory Council, the Office of Research, the Office of the Provost, who continue to support the University Scholar Series. Thank you. Now join me in welcoming Nidhi to begin our lecture.
Can you hear me? Yes, I think you can. Thank you so much. This is such a privilege to be here. What a fabulous turnout right on the edge of spring break. Thank you to the students and my faculty colleagues for that. So a few caveats are in order. I am going to give you a bird's eye view of some of the work that I've had the pleasure of doing in Alzheimer's disease and stroke. For those of you that might also be experts in these areas, please know that it might lack some of the detail given the short presentation time, but I welcome your thoughts and questions, and we're going to try to leave 10 to 15 minutes at the end for your questions. All right. A little bit about myself. As Carl mentioned, I do have research and training in adult neurological disorders, cognitive neuroscience, and multicultural issues. I'm keeping my comments pretty much about the adult neurology piece of this. Some of what I talk to you is also really nuanced by the fact that I've had the pleasure after my PhD to return to the clinical trenches and work as a medical speech pathologist in long-term care, acute care, and in private practice with persons that had dementia and post-stroke cognitive and communicative challenges. And I have to say, I think that has really changed my thinking in terms of the kind of research that I seek to do in these areas. I've also been very fortunate to have a lot of leadership opportunities, including currently being an Emerging Leaders in Aging fellow with UCSF and the American Geriatric Society. Very quickly, a few acknowledgements are in order. I'm soon approaching the end of my second year at San Jose State, and it has just been an incredible, warm welcome. It is not easy to leave colleagues and a established lab, which I had at Cal State East Bay, but you have really embraced me and really supported my research. So thank you to all the students, mentors, colleagues that are sitting in this room today. I wanted to give a shout out to my students who between midterms are here. Thank you so much. None of this would happen without you. And just to let you know that we have many collaborating sites that have shared in our vision of some things we're trying to accomplish. So at the outset, I should say to you that I'm a diehard optimist. It doesn't prevent me from being a realist, but I really believe that optimism is the strategy for building a better future. And in this case, I'm talking about a better future in healthcare and rehabilitation. I really think that if we don't believe that the future is going to be better, I think we're not able to step up and take the responsibility for crafting that vision of a bold and bright future. So I want to start by setting the frame and helping us understand some thoughts on wellness and disability that come out of the field of disability studies and disability theory. So I think if we have to understand the lived experience of persons with stroke or Alzheimer's disease or any other complex neurological disease, we have to start by thinking about wellness as this multidimensional state of being. So it's really about the existence of positive health, and if you have that positive health, you experience a high quality of life and rate yourself as having higher well-being than if you did not have wellness. It has many dimensions, so everything from intellectual to physical, spiritual, emotional, social, and so on. If we were to now shift our attention to think about disability a little bit, I think there are two models, and I think that our experiences in receiving our own health care and those times when all is not right with our health will lead you to realize that there are two prevailing models. The first is a medical model of disability, where the thought is really that the problem resides in the person who has the disability. Never mind that you don't have that much control or predictability that you are going to have a stroke or any other sort of diagnosis of a neurological entity. But this is what is a belief in the medical system, or in the medical model rather, is that the person with the disability is perceived as the problem, like something has to be fixed, it's broken, and it resides within the individual. A social model of disability, and this is, again, out of the work of disability studies, that field, is that the person with the disability is not the problem. Because really, what control do any of us have that we ourselves or a family member might not end up with a medical or complex neurological diagnosis? So in the social model, we're really thinking about maybe it's not the person with the disability. Let's step aside from that and think about all the structures and the healthcare systems and the providers and the way we frame the narrative of some of these disorders. So that's what the social model would say. We have to reconstruct and co-construct with our patients what should happen when someone has a complex medical condition. With that said, here's the dementia and stroke very quick 101. So dementia can be caused by more than 50 different conditions, and Alzheimer's disease is the most common cause of dementia worldwide. So dementia is really a syndrome or a cluster of symptoms that is characterized by something you acquire, something that is persistent, and does not impair only one cognitive domain, but really has widespread effects across domains. For something to be called dementia, it has to result in cognitive impairments that are severe enough to impair your social and occupational functioning. At this time, one person in America is diagnosed with Alzheimer's disease every 66 seconds. We have 5.5 million Americans that have Alzheimer's disease, and in California, we carry 1/10 of that just in our state alone. So it's a very important conversation when we think about dementia as a health issue for our state. Stroke is the leading cause of death and long-term disability in the United States. And you can essentially experience a stroke or a cerebrovascular accident when blood flow to the brain by one of its central arteries is either interrupted, is blocked off, or you have a burst blood vessel that results in bleeding in the brain. And one of the conditions that I care deeply about and work a lot with is aphasia, which is a communication impairment that most often results from stroke, but you can also get it from brain tumors, progressive neurologic disease, and brain injury. So when a person has aphasia, and I put some fast facts on your tables about aphasia, because it is a term that is really not well understood by a lot of people. But when a person has aphasia, their intellect is not affected, but their ability to show you that intellect by talking, understanding, reading and writing is grossly impaired. So you've got a person that, with very limited words, is trapped with this intellect that's ready to go. So how many people are aphasia aware? And since this is a term that will come up in my talk again and again, I just want to put it out there that international studies, when they asked lay people around the world, have you heard the term aphasia? What do you think it is? People were unable to distinguish it from a fruit, a skin disease, and a cerebrovascular kind of disorder. So it's really not understood well. I think in the United States, when former Congresswoman Gabby Giffords was shot at point blank range and had brain damage, she has aphasia. And she became sort of the poster child that actually lifted the awareness of aphasia immensely. Aphasia, new estimates suggest that this affects between 2.5 to 4 million Americans, and for decades it has been underestimated. So the incidence, this is the first representative number that clinicians and researchers feel is actually moving in the direction of more accuracy. Okay, so having said this about dementia and stroke, I want to talk about wellness and neurological disorders. What does that mean? Because you have someone where there has been a pronouncement, right, that something is wrong with your brain, or something is wrong in terms of you having acquired a progressive neurological problem. So how does one conceptualize wellness in someone with these complex conditions? I think the best answer to that is that you really have to frame this in a larger conversation about social justice and the rights that you have as a human and in your healthcare should something happen to you. How do we as a society get to walk away at that point when you have been a long-term and in most cases productive member of society and something happens to you? I don't believe that you will agree, or you'll agree with me, that we're not allowed to walk away from these folks who are out there in our communities. So let's frame that conversation about wellness for persons with neurologic diseases. In this case, we're talking about Alzheimer's disease and stroke. This is an area that has had, just amazingly wonderful work come out in the last 20 to 25 years. So it is a really positive time in researching interventions and access to services for these populations. So I'm going to take you on a quick tour through some of the most influential movements that have reshaped our thinking about what we should do as providers and certainly what we should do as communities. I'm going to start with the basics biopsychosocial model, and each of these are going to get about 10 seconds, just so you know. But you can ask me about these later if you like, and I'm happy to share more resources. So the biopsychosocial model, and many models like that come out of nursing, some from rec therapy, really talk about the fact that as a human being, you have certain needs that have to be met and fulfilled. And that doesn't change just because you are diagnosed with Alzheimer's or stroke, right? You have impairments in the face of those diagnoses, but you very much still have these needs that have to be met in order for you to have the best quality of life and some sense of well-being, even be it as it may that you may have these diagnoses. So this type of model says that you have needs for connecting with people and being out in your community. You have needs that are interpersonal and to be creative, and needs that you need to still feel needed despite the fact that you have these impairments or these disorders. So then a little bit later in the mid to late 90s, this idea of personhood came out, that we value our individual identities and who we are as people quite a lot, right? And there's something you take pride in that as an adult, that you have now acquired a set of knowledge, skills, and attitudes and become your person. So we can't quite say that you lose that quality of being human and being a person just because you have these types of conditions, right? So personhood says we can't just say because you have lost your cognitive capacity or lost your communicative capacity, you somehow are now less human and having a different set of criteria as far as your care and concerns being addressed. So this speaks to that idea that even if something were to happen to your cognition or your communication, there are other parts of you as a person that are very much able to be stimulated and nurtured and allowed to flourish via creative and social and symbolic types of interventions. The World Health Organization, had laid this down in 2001, where they said, we've had enough of this, where you have a health condition and there's all this pejorative conversation about what's broken, what's impaired, you can't do this, and you're just sort of, it's a very exclusionary conversation because it reminds you of how you are now less than what you used to be. So in 2001, they came out and said, we really need to start looking at what's the environment, what's making it worse. So you can't do anything perhaps about the fact that you have this health condition, but what is turning out to be a facilitator or a barrier in your environment? And what about you as a person or your life experience similarly is a facilitator or a barrier? So this changes how we look at interventions and who benefits and who should have the right to participate based on this thinking by the World Health Organization. And there's also a piece that they added in 2001, which was the participation piece that said, let's look at life roles. When you have Alzheimer's disease or you have had a stroke, so much has changed. Does every life role have to slip away? Is there nothing as far as what you did in your previous life that you're still able to access and benefit from with regards to stimulation and intervention? So with that, I kind of want to take you through some narratives, right? Because this is what we sometimes do as a society. We frame and construct certain perceptions of conditions, and sometimes we get very limited by the narrative we ourselves have constructed. And the answer to that also means that we ourselves have to step up and contribute to changing that narrative. So this is a typical set of images that might tell you a little bit about the way we frame dementia. There is sort of a gloom and doom narrative around it. You're losing everything. There are many myths about people with dementia cannot learn, they cannot remember anything. These have never been borne out in research, just so you know. And there's a lot of focus on the fact that if you contrast a healthy brain and severe Alzheimer's disease, oh my goodness, like this is horrible, right? But there's insufficient emphasis on the fact that that trajectory takes somewhere between 2 to 20 years. So the day you get the Alzheimer's diagnosis, are we supposed to throw up our hands and say there's nothing to offer you? Because that is happening to a lot of patients and clients in our communities. So I want to do a little fast point, counterpoint with you. So here's the point. Historically, we've always come out of a medical model and focused on what is decimated in Alzheimer's, right? Many researchers and clinicians have called this therapeutic nihilism. We focus on what is not able to be sustained or nurtured in the face of progressive neurologic disease like Alzheimer's. And what's worse is that caregivers, providers, entire societies also commit to this nihilism, right? We don't think anything we do will work. So we're almost at the point where we are not holding our feet to the fire to say, well, what is research showing us, though, in the last 20 to 25 years, right? So there has been this pervasive therapeutic nihilism. People will talk about how depressing it is to work with folks who have dementia, how long-term care is, your spirits sink when you walk in. So these are also things that we have constructed, and then they become self-fulfilling prophecies. There's always been an insufficient emphasis on the fact that patients with mild dementia, preclinical mild cognitive impairment, moderate dementia, have many spared abilities that they are able to utilize if we design interventions to stimulate people in that manner. And there are entire books written on the spared neuropsychological abilities in persons with dementia. But again, if you look outside of the last 25 years, none of that literature was even part of easily accessible evidence base. I think there's always been a poor understanding of the nature of human memory. So I'm sure you've heard where their memory is shot, they can't remember anything. But even in the way that our brains support memory, there are so many different parts and subsystems of memory that are served by different regions. So there is no such thing as your memory is completely lost. We see people with dementia sing songs, recall autobiographical details from years and years ago that they haven't even retrieved, and that remains very well spared, right? So we haven't understood, the traditional negative view has been based on a poor understanding of the human memory capacities. Research on treatment, because we have always spent a lot of money on Alzheimer's treatment, has been dominated by efforts at drug discovery. And I'm the first to tell you we have to keep doing that. We have to look at all aspects of treating Alzheimer's disease from a pharmacological perspective, from cell therapy, immunotherapy, gene therapy, all of that. But we don't need to drop every effort to look at rehabilitation in the interim, right? Why is that so relevant? Because if you trace a period between 2002 and 2012, 99% of the clinical trials, and by this I mean pharmacological trials, the actual number is 99.6, but 99% of clinical trials have failed. So here's the counterpoint. Dementia is a global epidemic. It's a public health priority in our country. And we now know a lot more about different dementias. We know a lot more about factors that slow down the decline once you have Alzheimer's. We know a lot about the kinds of interventions you should be receiving as standard practice and good care based on the last 20 to 25 years of research. We understand human memory systems and neuroplasticity in a phenomenally sophisticated way. So we know that the brain does not just sit and atrophy when you have Alzheimer's, and similarly, just because you've had a stroke and have expressed brain damage, it doesn't mean that you keep declining from that point on. There's a lot of evidence, as I mentioned, for spared abilities, and there is a substantial evidence base on the efficacy of several interventions. So I stumbled on this counterpoint quite by accident in my doctoral program, where I had the good fortune of working with a neuropsychologist whose mother had Alzheimer's disease, and she did not want to do an intervention study that looked like what was existing in the literature at that time. I was desperate for a job. I had to pay my way through doctoral studies. And so I became the clinical associate on this National Institutes on Aging funded grant. And the only word that comes to my mind today when I describe my affiliation with this work is life-changing. So I'm going to show you a visual tour of some images that came out of that work. And I bet you this will reframe the narrative a little bit for you. So several of the people who appear in these slides are actually real patients who consented for use of these images. In this work, we combined some intensive physical exercise-based interventions with communication and memory interventions, and also returned people with mild to moderate dementia in some role that they previously treasured back into their communities. So some of the pictures here, this is a client with moderate dementia who was at a food bank. He'd done that his whole life and went from his nursing facility to go participate in that task. These two images here are from some recent work that was funded by the Alzheimer's Association, looking at the use of iPad-based therapy apps and also traditional laptop-based activities and how persons with dementia participated. And when this grant was funded by the Alzheimer's Association, we'd go to a nursing facility partner. They were like, that's nuts. People with dementia are going to look at a laptop. They're going to do what with an iPad? Therapeutic nihilism, right? So our data, which we have actually since then compellingly published, showed otherwise. They showed that people, even with moderate dementia, were very interested. It's not, so this is the realist part of me. It's not for everyone, just like nothing is for everyone. You'll always find some clients who will have attrition out of a treatment trial or for whom a particular intervention is not a match. Same as with every other intervention known to mankind, right? So we don't have reasons based on evidence that people with dementia randomly reject all types of cognitive stimulation and intervention. In fact, a lot of our patients, and we call this social validation, where have we asked the person with dementia, what's your day like? How stimulated are you? And when you give them that chance, they actually say how dreadfully bored they are and that they want something to do and they want someone to talk to, right? So I think that's the other part. In the narrative we have constructed, we have desperately missed the patient voice. And only in the last 10 years or so has that kind of research, where you directly get the patient voice, even become sort of cool and exciting, and that we really think is a valid way to study whether we're making a difference with our interventions. These are the physical exercise interventions also, which people found laughable when we started, because the idea that somebody who is 80 years old would go through this 3 times a week, they did. Everybody lost weight, improved their bone density, improved their mood, and caregivers got so excited that in subsequent years of the grants, we had to get gym memberships for the caregivers because this was a legitimate way for them to spend time with their family member, and the narrative was non-negative because folks with Alzheimer's were getting better and fitter and stronger. These are other language memory types of games. That's headbands. There's reading, which we did a lot of in these studies, and then, of course, music, which is one of my personal favorites. So you can see that from this type of work that we did, and we've published up the wazoo on this as far as the impact that combining things like physical exercise, social re-entry into the community in whatever capacity is possible, and language and memory stimulation. We also noticed that when we were doing that grant that there was quite a powerful effect because we had a lot of student clinicians that we were training to deliver the interventions that were research-based. And we noticed it was almost like a 360-degree turn for a lot of our students who said they'd never considered a career in aging, they never thought that people with dementia were capable of this, and that it was sort of a mind-altering and perspective-shaping activity for them to be involved in some of these interventions. So we've also looked, and as have many other colleagues, that there is a long-term impact for students and future providers who are allowed the chance to be immersed in these environments where there's no other preset rule except, well, try it, see what happens with your participant, see if it works. And in most cases, they were blown away by how much the person was vested in participating and trying to benefit from the intervention. So a couple of points. When we think about interventions in rehab, I think there's certainly the conversation about direct interventions where you have a skilled or trained clinician or provider directly serving the patient, right? This is not going to solve our problems with the public health crisis that we have as far as numbers and how few people are getting out there from the health sciences, trained in gerontology, geriatrics, speech pathology, nursing, any of them where this is getting heavy-duty attention, right? So we are going to have to look at other models, which is where these indirect interventions come in, where if we were coming from a true social model of disability, we would not expect that everything in terms of improvement or maintenance of function has to come from the patient. We're going to have to decide that at some point, if a person cannot participate, we intervene by modifying the environment or training caregivers for wraparound care around this person, right? So when we look at caregivers, that definition expands to paraprofessionals, to students in training in the allied health fields, and lots of studies are showing that you can get very robust outcomes if you have a well-researched, clearly piloted, and protocol-driven approach to the types of interventions. So some other places to look for inspiration. You know, what's the need to look at interventions and rehab in a spotlighted way as far as making a difference? I think whether you call it logotherapy years ago, whether you look at the Japanese concept of ikigai or what the French call raison d'être, life participation, the fact is that we have a deep desire as human beings to strive for meaning, right? And because you have a stroke or Alzheimer's or you're an adult that has autism spectrum and so on and so forth, does not stop you from searching for how do I make myself meaningful? How do I make myself count, right? And that's the best argument from a philosophical perspective as to why we need to revisit the case for interventions. A few other things, you know, just a small point, but not really, this is a very big point, is what we've learned about neuroplasticity and the brain's ability to experience neurogenesis, to experience new synaptic connections, and to have strengthened synapses from repeated stimulation and enriched environments. We've known this part for the better part of 30 years at this point, and it's the strongest case for why you need to have enriched rehabilitation for persons dealing with the kinds of disorders we're talking about. So I think this is what inspires me the most, is that I think there's so much evidence that we have to have a new and improved playbook when we look to serving persons with these complex conditions. There are some well-known principles for successful rehabilitation, intensive person-centered intervention that hits many domains, kind of going after who the person was, what they did, what excited them, what do they want to do now in the wake of something like this having happened to them, and certainly looking at ways to infuse as much creativity, autonomy, and quality of life in the way we design and approach interventions. Just want to give you a quick example of music-based interventions, and if you haven't seen the documentary Alive Inside, I'm going to make a very strong plug that you make some time for it on spring break. But that's a good example, and we've researched this, and the interest with music-based interventions is because music is so universal and so easy to do and to document the efficacy of. And we've done this in long-term care environments. We've done it with persons with aphasia and dementia, including moderately severe dementia. And this is an example of a social validation outcome. It's also so rich metaphorically, coming from somebody with dementia, that we published this type of social validation outcome, that when you ask persons with dementia, what was it like for you to participate in that intervention? Did you like it? Would you come again? How would you improve it? And there hasn't been precedent for inviting our patients with dementia into that type of conversation simply because they have dementia. What input could they provide? And this statement will forever be an example for me of someone who spoke very little and what they answered when they were asked about the benefit of participating in a music-based language intervention. So let's understand the place of rehab in caring for persons with neurological disease. This is a powerful way to induce experience-dependent neuroplasticity. If you are stimulated, if goals are set for you to maintain or improve your function, and that is done in an intensive evidence-based way, good things happen for your brain. Even if you don't show every bit of improvement, sometimes it's maintenance. Sometimes you improve in some domains and not in the others. But rehab is a highly skilled clinical service. And just like any other intervention in pharmacology, the dosing and the regimen of rehabilitation matter. They've always mattered and they continue to matter. Sometimes when we look at our legislation, you don't see that. We finally, in February 2018, and everybody who's in PTOT or speech will recognize this, we finally lifted a 20-year Medicare therapy cap on physical therapy and speech therapy that required a person with a stroke to choose. What do you want to put your rehab dollars towards, walking or talking? Tell me on which day you would want to make that choice, right? We've had a double whammy in rehabilitation for a long time, and that is that the dose offered to patients, since we're talking about dosing, is either inadequate or skipped entirely. And it's just a travesty, right? So we would never skip doses or not offer pharmacological interventions to our patients, but we do that with rehabilitation all the time. The second double whammy is that our rehab outcome measurement in the trenches has not kept pace with research. So we're still expecting the person with moderate dementia to show an improvement on a standard memory test without a bigger conversation about why does that matter? Like, can they demonstrate their learning or behavior change in a variety of other metrics, such as everything from biomarkers to what they feel about the intervention that they're receiving, how their mood is, how their communication is, what their caregivers feel, and so on. So this means that we will sometimes indict a very robust rehab approach because we didn't get the standardized score results that we expected, even though every single person in the study said, I want to participate. I want to do this as long as I possibly can, right? So we have to learn how to balance how we indict rehab when we're using a faulty outcome measurement. So my last few minutes, I'm going to tell you how we are applying some of this. So for the last few years, I have, not to say that I'm not interested in the dementia piece, but I've taken some of those principles and extended it to the care of people with stroke and aphasia. So what we're doing at San Jose State is that we launched a Spartan Aphasia Research Clinic in July 2017. And I'm going to just, call out to my dean, Paul Casella, one of my mentors, Michael Kimbrough, without whose continuous support and collaboration, this would probably never have happened. So what we are doing in the Spartan Aphasia Research Clinic is we're taking some of those same ideas about how do we improve the rehabilitation services provided to persons with stroke and aphasia. So they're telling us the same story. With great difficulty, they'll get 10 therapy sessions sanctioned or 20 therapy sessions sanctioned. When that ends, there's absolutely nothing, and you take your long-term chronic condition and enjoy the rest of your life, right? So what we started as a pilot last summer, those were some of our numbers. We wanted to create an intensive and free stroke rehab clinic targeting the cognitive and communicative pieces of that. And those were our numbers last summer, where we had people spending 7 to 8 hours a week on our campus over 2 days. And they worked in individual therapy, group conversational retraining, and we have a therapeutic choir, which is to use the principles of singing to improve speech, or choral singing to improve speech. So what we're trying to do, and there is sort of some research nested within this, we want to know what difference it makes to treatment outcomes when we use an intensive approach like this versus standard care, which is you may get 1 therapy session a week for 1 hour. So by that token, we have 7 times increased the dosing of rehabilitation for people with this type of communication impairment. Another sort of little goal, always there, which is the training of future providers, because we're in the best place in the CSU system to be able to have great impact by looking at that. So we're trying to reframe therapy for aphasia, which is doing everything from looking at different ways of assessment, not just the how many words can you spit out a minute, which is very hard if you have aphasia, and not a outcome measure that responds very quickly. We want to know how people are feeling about how they participate in life roles, how their mood is, given that this is going on. Of course, we want to assess their aphasia, the type, the severity, how does it vary over the course of time or with different communication partners. And certainly to look at all barriers in their environment that we can help demolish. Thank you, students. I know you have a midterm at 1. Thanks for being here. And similarly, we're doing a lot of quality of life measures. We want to see, does an intervention like this, where you get to be a part of a peer community, where you for the first time are hanging out with other people that this has happened to, and are making new friendships, learning about your brain. So we do a lot of empowerment and education about what does the science around neuroplasticity mean? What should the person with a stroke or their family advocate for as they go about seeking services? We definitely have always a goal to get people out and into the community. This was a big hit of the summer. Everybody wanted to come to the King Library. And it's very apropos because we're standing right here right now. Here are some other numbers for us. We are continuing to expand. And I think it's a source of real inspiration, at least for me. And I know that the students join me in that. We're serving many more patients. Some of our numbers are we've already, and this is important because we still have a whole month of therapy to go. We've already provided 90 hours of individual therapy, 18 hours of group therapy, and over 40 hours of clinical assessment. Our tagline is "Got aphasia, we got you." So we are looking for funding at this moment to help us make the most of the pilot data that we have and to be able to look at how do we sustain, because we are free intensive services, right? There are plenty of places where you can go for this type of intensive services with a very heavy price tag. The going rate right now, if you went for a month of therapy and some universities are doing this, where you would go 4 days a week and about 3 to 4 hours a day, is about $20,000. And a lot of our clients who have lost livelihoods as a result of the stroke and aphasia are simply unable to afford that. So what's next? I think I want to tell you about the impact, which is what we're studying as the impact from our students. And these are just samples of reflections that our students tell us about. So here's one. I didn't think dementia patients were capable of this type of conversation and engagement. Another student said, when I changed my own view of things, I saw that persons with aphasia communicated volumes even when using few words. It's shifting that lens of perception. If we only look for what's broken from the medical model perspective, we miss out so much of the story of human potential and the indomitable human spirit that some of our patients are bringing to us. I think what's next on our wonderful campus, I think, is interprofessional collaborations for us. We want to bring in our occupational therapy and rec therapy colleagues into the conversation and to helping us really improve our outcomes. This is a list of some current research efforts, and I frame them as questions that we're asking. What do we not know about spared abilities? What do we not know about personal and environmental factors that influence a patient's response to rehabilitation? And certainly the question about future providers is very near and dear to my heart, because students tell us prior to having stepped into the aphasia clinic that they'd only heard it in a lecture or seen it in a video, and they haven't been around these many different types of people with aphasia all in a room telling them what they want out of the rehabilitation goals. So thank you for listening. I'm going to just stop right here and take some questions. Thank you for allowing me to give you a little glimpse of the work we're doing. Yes.
A very interesting framework. Do you think this could be applied to other forms of brain disease like mental health and mental illness?
It's a great question. I think I'll tell you the experience we have is that we see a lot of times we're not getting in there to intervene for the mental health outcome, but our clients tell us stories such as how important it is to just have a place to go, 2 or 3 times a week, to have a community that they're getting into, and what that does for their anxiety and depression. So I do think that that sense of community is more powerful sometimes than what even a highly skilled provider can bring you. Yeah, great question. Yes?
So the top
Uh, That's a great point. So what we're seeing in the aphasia clinic is that this is the same way we started in the summer, and the students can attest to this, that all the caregivers are highly anxious, very sort of concerned, what's going on, and, I'm so burnt out. There's a lot of statements about that. And then gradually you see them sort of retreating. So they're now sort of dropping and not coming, or more clients are coming via paratransit. And they're just talking about the sense of relief of caregiver burden for those 7-8 hours that patients aren't there. But more importantly, they're saying what it does for them to know that the person is actually happy somewhere in the aftermath of what has happened to them, and that they're not in a position to take that pain away. So it's a really good point. We have not studied it as closely as we should be studying it. Carl?
Nidhi, I'm struck in part because I'm going straight from here to a session on the CSU changes in remediation in the campus, that there's some parallels between the way the medical model, the social model, the World Health Organization model, and the way that we view student success on campus, which includes the deficit thinking of remediation and such, and moving away from that to one of a more empowering environment. Do you see any, have you learned anything that you can contribute that is appropriate for this medical system to address what our student success aspirations are for the campus?
So I definitely think that whole narrative about facilitators and barriers is really relevant to what we see that some of our students tell us, because they are, and speaking of which, there are some parallels where many of our students are actually in caregiver roles, number one. So setting that aside, I think this idea that if some of the barriers are removed, there are certain situations where any of our students could be successful. But since there's never a time and place where those barriers are stripped away, students will use this type of language to say it's sort of like trying to walk forward with a weight on. I don't know what to do about this. And there are certain things, such as whether you look at childcare, and other challenges that they're facing with their own health that really interfere with their ability to fully participate as a student, even though we have tons of opportunities on our campus to do so. Yeah.
So Rachel has the microphone.
Question.
Projecting.
Hi. So my question, you had two people back, they're talking about the caregivers. So as far as the environmental impact, how much caregiver buy-in do you get with the aphasia clinic? And do you see that as, if there is buy-in, that really helps the client, versus if the caregiver is sort of disconnected, how that may not help the client when he or she goes home?
It's a great question. So I think some of our students are here, so they can tell you that most of the caregivers are very much in support. At least in our clinic, our experience has been pretty positive. So they'll bring up concerns to us about things such as accessibility, or what about this? One of the challenges we are seeing is that we do have some young people with stroke and aphasia, and so now they have aging parents who are trying to decide what to do. And for those young people with stroke, those caregivers tell us that coming to a stroke group where there are not other younger people who have had a stroke, that is one challenge we're dealing with. The accessibility comes up sometimes, just getting here and driving and dropping off and things like that. But by and large, we've had a very good success. Most of our caregivers are telling us experiences of having nothing else by way of intervention or rehabilitation, because they are now 1 year post-stroke. And somehow, even though the research does not support that, that is something that's just inheritance of a bygone era, that most recovery will happen in the first 9 to 12 months, and it's a dosing issue in rehab. So we've actually seen a lot of support from our caregivers. Yeah.
I think we have time for one more question. Please join me in thanking Nidhi for a wonderful presentation.
Thank you so much.